So I'm Dan Spratt, a radiation oncologist from the University of Michigan. The standard of care and guidelines for over a decade has been for men with adverse pathology that undergo radical prostatectomy is to receive adjuvant radiation therapy. However, despite guideline recommendations, it's used by only about 5 to 10% of men with adverse pathology because patients have the option of receiving salvage therapy. The difference in adjuvant versus salvage therapy has now been tested in 3 randomized trials: the RADICALS trial, the RAVES trial, and the genomic trial, and 2 of which have been reported in the past year at ASTRO and ESMO in 2019. What these trials showed is that when you take all comers, it appears that early salvage radiation therapy has similar long-term outcomes to adjuvant radiation therapy, but lower toxicity. This supports the notion that early salvage radiation therapy should be a standard of care. The devil's always in the details. And when you look at the patients enrolled on those trials, and they reported those trials pooled together in what is called the artistic meta-analysis at ESMO of 2019, and the patients enrolled on that trial are actually somewhat favorable risk. Their preoperative PSAs were mostly less than 10. Those with Gleason 8-10 disease was the vast minority, and very few had seminal vesicle invasion. So I think that the findings are very applicable to average or lower risk men who happen to have adverse pathology at time of surgery, and early salvage probably remains the standard of care. But what we don't know is adjuvant still the standard of care for men with very aggressive disease. There's been numerous studies that have been done, a recent prospective study by Bobby Den at TJU that have shown that the Decipher classifier can identify very high-risk men at the time of surgery. And so the question remains, should these be men that we still continue to give adjuvant radiation therapy to over early salvage? Because the men enrolled on RADICALS and RAVES and part of the artistic meta-analysis are a much more favorable group, and they obviously did not do genomic testing to see if any genomic subsets, if they derive benefit of adjuvant over early salvage. It still is a standard of care to give adjuvant radiation therapy for adverse pathology, and I think if people are going to do so, they need to be using a genomic selection tool like Decipher to select those with the highest risk where it's really warranted to give them adjuvant instead of early salvage treatment.